hosting this hearing. Last November, this country experienced a historic moment. It was the largest voter turnout in a midterm election since 1914. We elected a new majority with a plurality of 10 million votes, which shattered all records in history of this country. And if you looked at the exit polling, healthcare costs was the #1 concern of voters, and more particularly the cost of prescription drugs. So holding this hearing on this bill is, in my opinion, keeping faith with the loud, strong message that came out less than a year ago through our democracy. And yesterday, we got more validation about this issue. Was Kaiser Family Foundation released its annual health benefit survey of employer-sponsored health insurance. The study found that the average premium for family plans has increased 22% since 2014, which has been a very low inflation environment. And last year to this year, it was a 5% increase, again, far surpassing the rate of inflation. According to the America's Health Insurance Plans, 23% of private health insurance premiums go towards prescription drugs, the largest share of health care costs, larger than doctor services, office visits, and hospital stays. In addition, we have seen the trend towards high deductible coverage as a desperate way of trying to moderate the increase of premiums. So again, there's an additional layer of cost which patients and workers have been experiencing. So, Dr. Sokol, when we talk about the brave new world of high deductible health insurance, lowering the list price of drugs, which, as you pointed out in your testimony, is really where the rebates are worked off, but they are not shared with workers. So could you kind of talk a little bit more about the way that all transpires?
Absolutely. First of all, let me just mention that from an employer perspective, you want to offer the best benefit you can to your workers. So an employer would, if possible, they would choose to offer the best plan they can. In the offering of these high deductible health plans, more and more, the more frequent offering for those plans, it already reflects how companies are struggling to pay for their bills, and they're sharing these agreements with patients. The real problem is that once you're enrolled in a high deductible health plan, automatically there's some sort of parallel mechanism to save money, like a health savings account, for example. Patients believe they're going to be protected like an insurance agreement. However, the price that they're going to be faced with is going to be the list price. So you cannot save your way to pay for the list prices that the insurers are negotiating down.
That was on page 7 of your testimony, which again basically says list prices before rebates determine America's cost-sharing amount. So again, the patient and the worker, again, is really sort of excluded from that.
Absolutely. They're always faced during the initial deductible, even for somebody who is fully insured, doing the cost shared. In cost sharing, percentage cost sharing is more frequent for the highest cost drugs. So patients are always paying over the list price, never over the negotiated price.
Thank you. And Mr. Isasi, again, AHIP, which has maybe not always been aligned with your organization in the past, but I mean, do you see any do you disagree at all with their analysis that prescription drugs now is sort of consuming the highest percentage of premium dollars?
Prescription drugs are 25% of premium dollars at this point. They've gone up exponentially, which means if any of us aren't on prescription drugs, we're still paying for them, right?
So again, if we're looking at a strategy, both public sector and private, in terms of just how we moderate and hopefully reduce premiums, I mean, that sort of trend just sort of screams out for Congress to act. Is that right?
That's exactly right. And just on this innovation question that keeps coming up, a couple points. Sovaldi, which was raised before. Gilead bought the drug from the researcher at the VA, right? And then their analyst said, enter the market this price, we'll make a ton of money, and then they quadrupled it. And then the patients in the VA couldn't afford to get the drug. That's innovation. The MS, we've talked a lot about MS. In the last 5 years, the drug went from 60,000 to 90,000. In 5 years, same drug. That's not innovation, right? That's not about innovation. In fact, what we know right now is 75% of the drugs that are coming to market because they're specialty drugs that can get the Medicare beneficiaries into catastrophic coverage where they only pay 5%. The government pays 80%, the plan pays 15%, right? Think about what it would mean if we had iPhones where 80% of the cost was government subsidized, 15% was paid by the iPhone retailer, and then 5% was paid by us, right? That's what we are living with right now. That's not innovation. That's why we don't have low-cost drugs.
And that's why we need to move on HR 3. With that, I yield
Absolutely.
back.
Thank you. Mr. Johnson from South Dakota.
Thank you, Madam Chair. I appreciate it. So, Mr. Garthwaite, I understood your comments earlier. It made sense to me that venture capitalists and, for that matter, other capital contributors, they could invest